So now let's start with the second type of uveitis, everybody. Again, going back to the classification, we are done with anterior uveitis. So now we are starting with intermediate uveitis. As we can see in the classification, and if we remember, intermediate uveitis basically means inflammation of pars plana. Yes. So we can also call intermediate uveitis as pars planitis. No confusion? Now, first of all, if I talk about the cause, the most common cause is idiopathic. In almost all the cases of intermediate uveitis, it is very difficult to narrow down onto a systemic association. So we simply say the most common cause is idiopathic. Secondly, it can be associated with diseases like Lyme's disease, or again sarcoidosis, or in rare cases multiple sclerosis, tuberculosis. But all this is very, very, very rare. I don't even want you to remember this. Only this much will do. Okay? Now, so what is the presentation or the symptoms? So the presentation or the symptoms of intermediate uveitis are bilateral, almost always bilateral floaters and blurred vision. In a minute, you will understand why floaters and why blurred vision. Okay, everybody? So now let's understand the anatomy of the eye to understand what are we talking about intermediate uveitis. See, this is a cut section of the eye I've drawn for you, just like everywhere I draw for you. This is my iris, everybody. So this is my iris. This is my pars plicatum. So what is this blue colored structure that we are talking about? Pars plana. Right? So where is the inflammation? The inflammation is in pars plana. Why have I drawn this diagram? If we see the iris and the pars plicatum, they are in contact with aqueous. That is why we saw in anterior uveitis, whatever problems were occurring anteriorly. We discussed aqueous cells, aqueous flare. Yes? But the pars plana, does it touch the aqueous? No. Pars plana is in contact with the vitreous. Do you understand why have I drawn this diagram? Yes? So whatever problem will occur will be in vitreous. Now what is the problem, everybody? Again, the definition of inflammation, there will be leakage of cells and proteins along with fluid. All that will leak into the vitreous. Now, all the cells that will leak into the vitreous now from the pars plana, everybody, will create a turbidity in the vitreous that will lead to blurring of vision. All these cells that will be seen in the vitreous, everybody, will cast a shadow onto the retina. See, everybody, if you don't understand this, light is coming. Light will strike these cells. So what these cells will do? These cells will throw a shadow onto the retina. When they throw a shadow onto the retina, what I see? Black spots in my field of vision. And because the cells are moving, this black shadow also moves. And that is what is known as floaters. Am I absolutely clear about this, everybody? Yes? So now let's understand the signs. Number one, almost always there is spillover anterior uveitis. Because there is no clear-cut demarcation between pars plicatum and pars plana, when there is inflammation of pars plana, a little bit of anterior uveitis almost always occurs. So it is very common to overlook intermediate uveitis because a lot of time clinicians think it is anterior uveitis. That is why it is important to be able to diagnose it by doing what, everybody? Fundus examination. Number two, everybody, there is something called as snowballs and snowbanking. These are the two classic words used to describe intermediate uveitis. Now these two words are again very easy to understand if you understood the anatomy that I just explained to you. Let's see here, everybody. What did I say? That cells are leaking from the pars plana into the vitreous. What is vitreous? Vitreous is a gel. Now what will occur? The gel will lead to clumping together of the cells. So now all these cells will be clumped together. Yes? Vitreous is transparent. Within the transparent vitreous, you will see white clumps of cells. White clumps, can I call them snowballs, everybody? Yes or no? Yes. So that is what snowballs is, everybody. Okay, everybody? So there is aggregation of cells in vitreous. Yes, I know it is easy. I can't make it difficult for you. This is easy. Intermediate uveitis is a very easy topic. Howsoever much I want, I can't tell you more about it. This is this easy. Yes, this is this easy. Yes. Now what is snowbanking? Again, let's go back to this. Okay. Now, these snowballs which were forming, they will keep on becoming larger, larger, larger. When they become larger, they will coalesce. When they will coalesce, they will form a sheet. Okay. Of opacity or white color, I can say. Yes. So this sheet of opacity that will form will look like a bank of a river which has frozen. So snow bank, baraf ki chadar. You understand, everybody? So it is the same thing. What is first of all just leakage of cells into the vitreous is turning into snowballs as aggregates, and then those aggregates are becoming larger, coalescing and forming a snow bank. Am I clear to everybody? So I can call it basically a fibrovascular plaque. Am I clear to everybody? When they have organized, they have formed a large plate or plaque. I will show you an actual photo for this. Slightly difficult to see, everybody. So this is fundus examination. I hope you can see the red color of the fundus here, everybody. Yes. Now in fundus examination, this is the center of the fundus. In the periphery, in this zone, everybody, we see a deposited yellowish whitish layer, everybody. This is known as a snow bank. Okay. This is right near the periphery of the retina. I hope you understand. Where will this be? This will be near the periphery of the retina. Yes. This will not be on the retina. This will be at the periphery of the retina. Am I crystal clear about this? No confusion? Done. Moving back, everybody. Number 4. The patient has cystoid macular edema. Inflammation leads to edema associated. Again, the most common cause of visual loss. Done? No confusion? That's all, everybody. These are the important signs of intermediate uveitis. So we know the sign symptoms. So let's quickly move on to the treatment. So the treatment has a 4-step approach. First of all, everybody, let me appeal to your common sense. What should be the drug given? It is inflammation. Inflammation means you should give steroids. So as step 1, we give steroids. But what is the route of steroids? Will you give topical steroids? No. Obviously, the problem is in the posterior segment. But will you give intravitreal steroids? No, we have a better way here, everybody. That is called as posterior subtenon injection. Okay. Posterior subtenon injection, PST. If this does not lead to the resolution, then we again move to steroids, but systemic. Step 2 of treatment. Step 3 of the treatment, if systemic steroids also don't lead to the resolution, everybody, then we have to move on to immunomodulatory therapy. Basically, the use of drugs like azathioprine. And lastly, if everything fails, then we need to do what, everybody? Pars plana vitrectomy. We need to remove the vitreous plus photocoagulation of snowbank. Snowbank was a fibrovascular plaque, so the vessels will bleed sooner or later, everybody. Yes, so we need to photocoagulate the snowbank also. So this is a 4-step approach for the treatment of the simple condition called as intermediate uveitis. I hope everybody understands this very easily. No confusion about this. Done, guys? So now that we've done anterior uveitis and intermediate uveitis, everybody, we will be starting with the third type of uveitis amongst our classification, that is posterior uveitis. Posterior uveitis, as we understand, is inflammation of now what, everybody? Choroid plus retina. Now, in this, when we see the clinical features, everybody, we will note that almost all the clinical features are due to involvement of the associated retina along with it. Okay? So number one, the patient complains of floaters. Choroid, retina, both are located near the vitreous. So when there is choroiditis or retinitis, there is associated vitritis. And as explained just now in intermediate uveitis, due to the vitritis, due to the cells in the vitreous, there is floaters. Secondly, there can be loss of vision, but this loss of vision is characteristically painless. Now, there is no clear reason why the loss of vision is painless, even though the disease we are discussing is inflammatory in origin. But usually it is explained like that in anterior uveitis, there is severe pain due to ciliary muscle spasm. Actually, not due to the inflammation as such. Yes. So, because there is no ciliary muscle involvement here, there is no spasm, and that is why there is almost a painless loss of vision. Thirdly, the patient complains of scotoma. Scotoma, all of us know, everybody, a dark area in the field of vision. The patient will also complain of metamorphopsia. What is metamorphopsia, everybody? I hope you know. There is distortion of images. So the size may appear large or small, everybody. And lastly, due to retinal irritation by inflammation, nerve fibers are getting irritated. So there is photopsia. Photopsia, that means flashes of light perceived. The nerve fibers get irritated, so they fire ectopic impulses to the brain, and that get appeared as flashes of light. So all these features, metamorphopsia, photopsia, scotoma, they are also seen in retinal detachment as a disease. But here we are discussing uveitis. I hope we understand that. Yes? Now we know this, everybody. What about the causes? So causes number one are infectious. Usually, posterior uveitis is due to infectious causes. Like A, most common infectious cause, toxoplasmosis. Toxoplasmosis. So, what are the specific presentations of toxoplasmosis posterior uveitis? In acute cases, you will be able to see something called as the headlight in fog appearance. I'll just show you the photograph and explain. Whereas in chronic cases, you will see a punched out scar. Okay, everybody? Yes? So let's see the photograph of something called as headlight in fog appearance. Everybody, let's see this photograph. What do we see in this? We see the fundus, but the fundus is very hazy. And in this central area, it looks as if there is a beam of light shining through the fog. So why is that, everybody? There is associated severe vitritis, which leads to turbidity, fog, everybody. Behind that fog, we see a foci of granuloma shining through. This foci of granuloma is like a headlight. So I hope you understand what I'm trying to say here. So this vitritis is the fog, and this foci of granuloma is the headlight. So it looks as if a headlight in fog appearance. Am I clear here, everybody? Yes? Everybody? Are we crystal clear about this? Brilliant, guys. Now let's see the second image here, everybody. This is a chronic case of toxoplasmosis. So the lesion has already healed. The granuloma, the foci of granuloma that has healed and has left a punched out scar. Am I clear to everybody? Yes? No confusion about this? Now, moving back, everybody, we should remember that cats are definitive host for toxoplasma. I have mentioned the word foci of granuloma. Yes? So we say toxoplasmosis causes focal chorioretinitis. See, there can be two types of inflammatory disease. Multifocal with multiple spots, or focal, that means only at one spot. Whether we saw the active image or whether we saw the chronic image, we were able to see only one foci, everybody. Yes, one foci chronic, one foci active. Am I clear? So focal chorioretinitis. I hope we are crystal clear about these simple facts about toxoplasmosis. Done? Now, second important cause is toxocariasis. Nothing specific to discuss here. Not a very common cause of posterior uveitis. If at all you want to discuss something, please understand this causes unilateral loss of vision and it presents with leukocoria. Leukocoria is white pupillary reflex. Okay. Thirdly, everybody, important cause is CMV retinitis. CMV, cytomegalovirus retinitis. Why is it important? Because CMV is the most common cause of visual loss in ocular, I can say, HIV. Okay, so this is the most common opportunistic infection, everybody, with yes, HIV. So this is the most common cause of visual loss also. Now, what is the specific presentation in case of CMV, everybody? So the specific presentation can be in the form of, everybody, pizza pie appearance. Again, I'm writing the name, then I will explain you the photograph. Pizza pie appearance, or it is also called as scrambled egg and ketchup appearance, or the third name given is brush fire extension. These are the three specific appearances you will land up with in cases of CMV retinitis. Let's try to understand them through the images, everybody. Let's see this image, everybody. In this, what do we see? White color exudates. Okay. And all these red colored perivascular hemorrhages. So what does it look like, everybody? A pizza. What does pizza have? Red colored sauce and white colored cheese. Yes. Or I can say scrambled egg, white color, along with ketchup on the side. Okay. Scrambled egg and ketchup. I hope there is no confusion about this. Yes. Or if you see that the scrambled egg is not there or the cheese is not there, only you see perivascular hemorrhages, then you can see such an image, everybody. In this image, what do you see? You see exudates are lacking. It is mainly a lot of perivascular hemorrhages. It is looking as if a bush. You understand a bush, everybody? It looks as if a bush is on fire, everybody. Yes or no? So it is called as a brush fire extension. That all the bristles of a brush or a bush are burning. So brush fire extension in one specific direction. So both these are images related to a CMV retinitis. Please remember all the three causes that we have discussed, everybody. A, B, C. They are causes of focal chorioretinitis. Done? Now I'm writing D, E, F. D, E, F. Herpes simplex virus, tuberculosis, and syphilis. These three are causes of multifocal chorioretinitis. Nothing specific about them. So just mentioning multifocal, everybody, whereas the above three were focal chorioretinitis. Am I absolutely clear about this, everybody? No confusion. So these are my infective causes, everybody. Causes infectious. Now let's move on to the second, non-infectious. When I discuss the non-infectious causes, number one, everybody, sarcoidosis. What is the specific clinical feature of sarcoidosis, everybody? It causes something called as candle wax drippings appearance. Okay. Everybody see this photograph. What do you see? Perivenular sheathing, everybody. Yes. Wherever the vessels are going, along that you see a lot of inflammation. So there is perivenular sheathing, everybody. Yes or no? And it looks as if a candle has burned and all the wax is lying down in a zigzag manner. So this is sarcoidosis. Candle wax appearance. Done, everybody? No confusion about this? Along with this, a second sign that is specific for diagnosis of sarcoidosis is called as Lander's sign. What is Lander's sign? Pre-retinal nodules. That on the anterior surface of the retina, that is the interface of the vitreous and the retina, you will see some nodules. I don't have a very good image of it, guys. Just remember this, pre-retinal nodules, sarcoidosis, granulomatous nodular disease. Am I clear to everybody? No confusion? Then the second cause is something called as Behçet's. So Behçet's can cause anterior uveitis as well as posterior uveitis. Then the third cause is birdshot chorioretinopathy. Again, it is these are very rare causes, so very difficult to find very crystal clear images. So I don't have a image for this again to show you, everybody. But if you understand through your imagination, everybody, bird droppings, everybody, beat, yes or no? So you will see small drops of white colored, yellowish colored foci scattered throughout the fundus when you look at the fundus. And that is why this gets known as birdshot chorioretinopathy. Important to remember, this has HLA-A29 association. Then there is something called as serpiginous choroiditis. In this, the areas affected, the inflammation moves as a serpentine motion, like a S shape. That is why this is known as serpiginous. Again, the important question is, this is HLA-B7 associated. Right, guys, done. These are the important non-infectious causes of posterior uveitis. I hope I am crystal clear about this. Done, guys. Now that we are done with posterior uveitis, everybody, causes. What is the treatment of posterior uveitis? The answer should be very clear. Steroids. And which steroids, everybody? Systemic or intravitreal. I don't think what I can explain you in this. There is inflammation in the posterior segment. So either you can give systemic or you can give intravitreal. But there have been some other approved treatments, everybody. Okay. So there is something called as adalimumab. This has been approved for non-infectious posterior uveitis. Non-infectious posterior uveitis by a trial called as Visual 1 and Visual 2. Please remember the central examinations, what is now INI-CET, they sometimes ask questions on these kind of trials. So adalimumab is very commonly used drug to treat cases of posterior uveitis non-infectious causes. Similarly, there is a drug called voclosporin, which is used, and this was by Luminate trial. Then a known drug, I hope all of us know, sirolimus. Sirolimus is used, given by the Sakura program. So all these three are novel treatments which have been approved for the treatment of posterior uveitis non-infectious causes. Done, everybody? That's all about posterior uveitis from my side. A very simple, short disease with a lot of characteristic names like candle wax appearance, toxoplasma. You need to remember headlighting fog and all the images I have shown you. Now, moving on to the last type of uveitis that we want to discuss here, everybody. That is called as panuveitis. Now, what is panuveitis, everybody? Panuveitis means inflammation of all the parts of the uvea. Crystal clear cut, no confusion, simple, done. Now, what are the causes of panuveitis? There are lots of causes of panuveitis, but I'm going to discuss two important causes of panuveitis with you here. Number one, VKH syndrome, also known as full form, useless full form, but still we'll try to remember this as medical students. Vogt-Koyanagi-Harada syndrome. This is one of those full forms which nobody will ever ask you. But the first time we read it in our third year, we are very perplexed by it. So we learn it by heart. Vogt, Koyanagi, Harada. And we go, to our friends and ask, तेरे को VKH का full form पता है? And because they cannot answer, we feel pride. Medical students have a tendency to learn all the useless stuff. All of us are wired like that, believe me. Vogt, Koyanagi, Harada syndrome. Now, VKH syndrome is a multi-system disease. This multi-system disease affects the eyes, so it has ocular clinical features. Plus, it affects the integuments, or I can say skin. Plus, it affects the ear. Plus, meninges. What is common between all these four systems, everybody? Eye, ear, skin, and meninges. Melanocytes. So, VKH syndrome is postulated to be damaging the melanocytes, basically. Yes? So let's see. What will occur in skin, everybody? Vitiligo. White patches. Done. What will be in ear, everybody? Tinnitus. That ringing sensation in the sound. Meninges. Meningoencephalopathy. Okay? So of each system, I have told you one characteristic thing. Now we come on to the eye. In eye, what are you seeing, everybody? We are discussing VKH syndrome is a cause of panuveitis. So that means what is the ocular sign, everybody? Bilateral granulomatous panuveitis. Am I clear? No confusion about this here? Then, secondly, it presents with a characteristic sign which is known as Seguira sign or Suiguira sign. Okay? What is Suiguira sign? Perilimbal. Around the limbus, we see vitiligo, white spots, depigmented lesions. We have sunset glow fundus due to associated retinal pigment epithelium atrophy. Because there is RPE atrophy, instead of the red normal fundus color that we get, instead of that, when we look at the fundus, we get an orangish, dull orange color. So when the sun is setting, everybody, there is a dull orange color. That is the kind of color we get. And that is why it is known as sunset glow fundus. The last important sign is exudative retinal detachment. Am I clear? These are the important signs of a case of VKH syndrome. Usually, whenever we get a question on VKH syndrome, all these are mentioned together. A patient complains of ringing sensation in the sound, in the ear. On examination, there are depigmented lesions scattered throughout the arms or the face. And the patient has features of uveitis. Am I clear to everybody? Done? Now, the second important cause of panuveitis. The second important cause of panuveitis is this. Sympathetic ophthalmitis. Sympathetic ophthalmitis. First of all, what is the ocular clinical feature of sympathetic ophthalmitis? Again, see, understand, this is a slightly just a tricky question for my brain. Sympathetic ophthalmitis is the cause of panuveitis, yes? So I am saying, what is sympathetic ophthalmitis causing in my eye? Ocular clinical feature. The answer is again granulomatous panuveitis. Are we clear what I am trying to say here? Yes? Now comes the second question. What is the cause of sympathetic ophthalmitis? Now this is what we know, everybody. All of us know that we read this in the chapter trauma. So the answer is trauma. But the question comes, which type of trauma? Blunt trauma or penetrating trauma? So blunt trauma, we have already read all the signs. There is a complete video on blunt trauma. Yes? The answer here is penetrating trauma. Then, what type of trauma? That means accidental or surgical? The answer is accidental trauma. Trauma to which part of the eye? Ciliary body. So actually, nobody is interested in asking you the word trauma. Trauma is the word around which questions are based. So they will ask you, sympathetic ophthalmitis occurs due to trauma too. Am I clear to everybody? Done? Now, once we understand the cause, let's understand why does this occur. Pathogenesis. So to explain the pathogenesis, I usually like to tell a story. A Hindi movie story. I will speak it in Hindi, everybody. If you don't know Hindi, please just skip this part. It doesn't sound funny in English, that's all. You will be able to understand it even without the story, guys, okay? So, let's talk about the 80s movies, 80s and 90s movie. सभी movies में same story होती थी. What was the story, everybody? There was a hero, there was a heroine. दोनों में हो जाता था प्यार. Yes? जब प्यार हो जाता था तब हीरोइन को पता लगता था that the hero is poor, हीरो गरीब है. हीरोइन अपने फादर को बोलती थी मेरे को उससे शादी करनी है. हीरोइन का फादर बोलेगा हम अपने से नीचे वाले खानदान में शादी नहीं करेंगे. राइट? हीरोइन बोलेगी मैं तो शादी उसी से करूंगी वरना नहीं करूंगी. नाउ हीरोइन इज रिच, हीरोइन्स फादर इज रिच. सो हीरोइन्स फादर विल स्पेंड सम गुंडास, goons. Yes? So, cut to the scene. There is a road, ambassador car. Outside the ambassador car, हीरोइन खड़ी है. हीरोइन के फादर ने पकड़ रखा है. हीरोइन बोल रही है मुझे छोड़ दो. नहीं छोड़ रहे हैं बट ऑब्वियस है. थोड़ी दूर हमारा हीरो पिट रहा है, 4-5 गुंडे उसको पीट रहे हैं. राइट? अभी पिटाई पूरी हो गई है, हीरो पिट चुका है. एकदम से हीरोइन छूट के भागने लगेगी. जब वो भाग रही है, शी इज वेयरिंग अ सलवार कमीज, उसके ऊपर दुपट्टा है, वो उड़ रहा है. बहुत इंपॉर्टेंट है दुपट्टा, देखना. वो उड़ते हुए दुपट्टे के साथ हीरो के पास पहुंचती है, दुपट्टे को लेती है, उसको फाड़ती है. क्यों फाड़ रही है भाई? फर्स्ट एड करनी है. यस? सो नाउ शी इज डूइंग द फर्स्ट एड. हीरो के जख्मों पे फर्स्ट एड कर रही है. अभी तक सिर्फ स्टोरी थी यार. पैथोजेनेसिस क्या है? जब वो हीरो के जख्मों पे फर्स्ट एड कर रही है तब वो क्या बोलेगी हीरो को? वो हीरो को बोलेगी चोट लगी तुझे, दर्द हो रहा है मुझे. मतलब what am I trying to say here, everybody? Pathogenesis is trauma to one eye. Okay? This is the hero. चोट लगी तुझे, trauma to one eye. But the sympathetic ophthalmitis is developing in the other eye. दर्द हुआ मुझे, हीरोइन को. Am I clear? Trauma to one eye. But sympathetic ophthalmitis develops in second eye. So the second eye is showing sympathy. You understand, everybody? Second eye is showing sympathy. It is known as sympathizing eye. By showing sympathy, it is causing a condition called as sympathetic ophthalmitis. I am sympathetic towards you, that's why I have inflammation, sympathetic ophthalmitis. So, to remember, चोट लगी हीरो को, दर्द हुआ हीरोइन को. Trauma to one eye, sympathetic ophthalmitis develops in the second eye. Am I crystal clear, everybody? Yes? Once we understand this, we understand that sympathetic ophthalmitis will not develop in a day. There has to be some time in which the antigens are able to sensitize the other eye. This is what is important. So this is greater than 2 weeks. Am I crystal clear? So the traumatic eye is not developing the sympathetic ophthalmitis. Traumatic eye is not sympathizing. The other eye is sympathizing. Am I absolutely clear about this? Why is this important? Because we know we have a 2-week window now. 2-week window to prevent sympathetic ophthalmitis. Am I clear to everybody? That is the question. How to prevent sympathetic ophthalmitis? Okay. Within 2 weeks. Enucleate traumatic eye. Are we clear? What is the thought behind this, everybody? Let's say that traumatic eye is so severely damaged that the patient is already blind. Now we know that I have lost one eye. Now due to the sympathetic ophthalmitis, the other normal eye may also get affected. So within 2 weeks, I will enucleate, everybody, the traumatic eye to prevent sympathetic ophthalmitis in the normal eye. Am I absolutely clear about this? Yes or no, everybody? Yes. But if you ask me, what is the treatment of sympathetic ophthalmitis? Then the answer is steroids. Do you understand the difference between these two? Prevention, enucleation. But if sympathetic ophthalmitis has already occurred, then enucleation cannot help. Then we have to give steroids. Am I crystal clear, everybody? This is usually the 2 words that students keep on confusing themselves. A lot of times in lectures, when I ask students, everybody in live lectures, what is the treatment of sympathetic ophthalmitis? They say enucleation. Please remember, treatment is not enucleation. I cannot emphasize on this point enough. Right, guys? That's all about sympathetic ophthalmitis. That's all about pan-uveitis. That's all about my types of uveitis. Okay, done? So now that we're complete with uveitis, and at the end we have just mentioned a word called enucleation, let's discuss a related topic, a miscellaneous topic, we can say, surgical removal of eye. So there are three ways we can remove the eye. The first is enucleation, then we have evisceration, and then we have exentration. What we are trying to do here is understand the difference. So enucleation we have discussed at a lot of places. I hope you know the definition. If not, I'm writing it for you. What is enucleation? Removal of whole eyeball. I am not saying HOLE whole. I am not creating a hole. Whole means complete. Along with optic nerve. Okay? Now, as you will be able to see in the image here, everybody, what we see is the upper eyelid and the lower eyelid. Yes, upper eyelid and lower eyelid. In the center, there is no eyeball. So the complete eyeball has been removed along with the optic nerve. Done? Now, what are the indications for this? So indications are, number one, we should know this is the treatment of choice in cases of retinoblastoma. And number two, we just discussed enucleation is done in cases of sympathetic ophthalmitis. No, yes, it is done to prevent sympathetic ophthalmitis. That means it is actually done in cases of trauma. Okay, there was a penetrating trauma which could have caused sympathetic ophthalmitis in the other eye. So enucleation is done in trauma, not in sympathetic ophthalmitis. What is the contraindication of enucleation, everybody? Panophthalmitis. Now, let's move on to the second surgery, evisceration. If you see the photograph and if you have ever read the definition, you should be able to correlate. If not, I'm writing the definition. So what is the definition of evisceration? Removal of all layers of eyeball except sclera. So we are removing all the layers of the eyeball, cornea, uvea, retina, everything. But we are not removing the sclera. So if you will see or note the image carefully, you will be able to see that this is where my cornea must have been. We have cut the cornea, we have gone inside, we have scooped the whole inside contents of the eyeball. And this is my sclera, which remains throughout. Okay, everybody? No confusion about this? Now, what are the indications? If we have read the chapter on lens, we already should know. The answer has to be endophthalmitis indication. What is the contraindication? Retinoblastoma or a malignancy. You should not attempt it in case of a malignancy like retinoblastoma. Instead, enucleation should be done. Now the third, everybody, exentration. This is the most radical surgical removal, everybody. In this we say removal of eyeball and orbital contents. Okay? We have removed the eyeball, yes, but we have also removed the upper eyelid, the lower eyelid, the orbital contents and everything that was there. Am I clear to everybody? Why is this done? This is done only in orbital mucormycosis or rarely in metastatic tumors to orbit. Okay? So basically very radical procedure. When we know to save the other structures, we have to completely remove everything. That is when exentration is done. Right, guys? So these are the three surgeries, everybody. Again, you can see the images. Enucleation, eyeball only. Evisceration, except sclera, everything. And exentration along with the eyelids and everything. So total complete removal. Done, everybody? Now, to end my discussion on the uvea, a very small topic which has been asked once or twice, everybody, gyrate atrophy. This is a type of choroidal atrophy. Now, to discuss the questions on this, I will simply give you a mnemonic, and through that mnemonic only, I will just teach you this disease. G for gyrate atrophy. So, the mnemonic is the name of the airline, Go Air. Why does gyrate atrophy occur? So, O for ornithine aminotransferase. Gene mutation. Okay. So, the gene encoding ornithine aminotransferase is mutated. Then AI. What is the treatment? The treatment is arginine diet restriction. Why, everybody? Because ornithine is formed from arginine. So, arginine converts into ornithine. Due to arginine being absent from the diet, ornithine will not form. So the already excess ornithine that is there in the body, it will not become more increased in levels. And lastly, R for recessive. So its inheritance is autosomal recessive. That's it, as simple as that. Easy peasy, everybody. That's all about gyrate atrophy. That's all about my chapter uvea. I hope you have been able to understand that the main topic that we need to read is uveitis. Again, I will reiterate, a question is not always asked. Very important to learn the characteristic features, keratic precipitates and so on, the festoon pupil. But if a question is asked, it will almost always be an easy question which you should be able to solve, and not in every examination will you come across a question from uvea. Right, guys? Done? That's all about the chapter uvea.